sharp slides. So you can ask me any questions. This part of it is going to be completely clinical. My goal is to get some clinical studies because we're faced with these questions. What do you do with this kind of patient? What do we do with that kind of patient? Things like that. So with no further, try to see if you can use your app. Can you see the question there? It says, which of the following drugs is not a lipid lowering one? Does it show up on your app, guys?
Yes.
What does it show up on there? If you put the wrong answer, you can always clear your answers. But right now, it's there's a big fight between. So the question is, which is not a lipid lowering one? So we have about 92%. We have 8% who say Lipitor is not a lipid lowering one, and we have 92% who say Viagra is not. Viagra is not lipid lowering. So I don't know if this will advance automatically, but it will not. Okay, this people have already answered, but when were the latest lipid guidelines initiated? When were the latest lipid guidelines initiated? I mean, so Ryan was talking about the old ones, which was the ATP 3 in the 2002 era. And then, we talked about, it has to be less than 100 for if you have this risk factors, less than 130, things like that. Then came the so-called, the latest lipid guidelines from 2013. 14% picked that. While 79% picked 2018, which is also right, but it's not the latest, it was not initiated, it's just an update to the 2013 guidelines. So the 2013 guidelines is what came out, and then the 2018 was the latest update to the 2013 guidelines. I'm glad that you guys are able to use the app pretty good. Okay, this doesn't involve the app. So according to the 2013 guideline on the treatment of blood cholesterol to reduce your atherosclerotic cardiovascular risk, match the following patient types with the severity of statin therapy. So let's start with 79-year-old man with clinical atherosclerotic cardiovascular disease. Which box would you put him on? Left or the right? Anyone? Left or right? Why? Over 75. Okay, how about 66-year-old woman with clinical atherosclerotic cardiovascular disease? Right. How about 45-year-old man with a fasting LDL of 210? I hear both. I hear both left and right, okay? How about a 50-year-old woman without diabetes, fasting LDL of 85 and an estimated 10-year atherosclerotic cardiovascular disease of 7.5%. Okay, the reason I put that up is just to get your mind going. Okay, so when we go back, there's moderate and high intensity. So what is moderate and what is high? So when you talk about high intensity statin therapy, there's only two in the market right now. We're not talking about PCSK9, we'll get to that. Mine is completely statin focused. We'll touch base on the PCSK9 and I'll tell you why later. So high intensity is something which can lower your LDL by more than 50%, and you have two. One is atorvastatin or Lipitor, however you want to call it, 40 or 80 milligrams, right? Crestor or rosuvastatin, 20 to 40 milligrams. These are the only two alternatives for high intensity statin drug. Moderate intensity, we have a whole bunch of them, including atorvastatin and rosuvastatin, but lower doses. 10, 20, 5 to 10 of Crestor, and all the other ones. Low intensity statin, you have simvastatin, a low dose of the so-called weaker ones. Randall very nicely said every statin is a little different in several ways. The only thing I would like to ask Randall is, he talked about the two safe ones. One was pravastatin and Livalo, pitavastatin. But I thought, in my opinion, rosuvastatin is also one of the safer ones because pravastatin and rosuvastatin have a similar pathway. Now, pitavastatin is a completely different pathway, which is Livalo. In Livalo, it clinically has the least myalgia I've ever seen, practically speaking. Okay, but Livalo is the new kid on the block, people, and surprisingly, it actually lowers the cholesterol significantly. It's the last trade name drug out there.
Talking about drug interactions, mainly. That's what you're
drug interaction. Yeah. So I'm not going to go through the laundry list here. So let's go to the guidelines. Number one, you need to have healthier lifestyle habits. No smoking, activity, no sedentary lifestyle. Watch your diet, right? So all of these things, and lose your weight. So if you're above the age of 21, okay, then this is valid. So do you have clinical atherosclerotic vascular disease? If you say yes, if it's high intensity statin, if you're less than 75, it is moderate intensity statin if you're greater than 75. But for primary prevention, meaning if somebody is, that's a whole different ballgame. Okay, let's say if you didn't have any atherosclerotic heart disease, go no. Is your LDL greater than 190? If your LDL is greater than 190, high intensity statin. Okay, fine, your LDL is not greater than 190. Are you diabetic and your LDL is greater than 70? And you're between the age of 40 and 75? Then you got to be on a statin. So you can either be on the moderate or the high intensity. So how do you pick which one? That's where you got to calculate the so-called 10-year atherosclerotic cardiovascular risk. So if it's greater than 7.5%, then you put them on a high intensity statin. If it's less than 7.5%, you put them on a moderate intensity statin. These are the guidelines. These are not what I'm trying to tell you, but these are the guidelines. Additional factors, which Dr. Sharp was touching base on. So what happens, sometimes people are on the gray zone area. Man, do I really have to put them on a statin? Do I really, do I not? And, are they really need a high intensity, or do they can settle with moderate? You have a lot of things which will go on in your mind when you look at case studies, when we see patients in real life. You have to use other factors. Is their primary LDL above 160? Do they have a family history of premature coronary artery disease with onset less than 55 years of age in a first degree male relative? I don't want to read the whole slide. But calcium score, I've been totally against the calcium score deal because all along I've been bad-mouthing the so-called calcium scans. But there's a reason now I use them, just as a marker. So if your calcium score is greater than 300, it itself is a risk factor. If your ABI is less than 0.9, it is a risk factor. So these are not risk factors, these are, as he said, risk enhancers. So these can be used as added ammunition when you are talking to the patient. Hey, this is why I think you should be on a statin drug. This is why I think maybe you don't need to be on a statin drug. You see, it should be a shared decision making. Not for medical legalities, but we have to be sympathetic to the patients. Because it's easy to just pull a drug and just let people have it, right? But people are very, very, very anti-statin, right? So have you ever noticed why the guidelines keep changing? Why do guidelines change? I was just sitting there and Randall was talking about us looking at the history of the guidelines. And I'm like, we live in a world of all kinds of crookedness. The only reason the guidelines got updated in 2018 is because we got PCSK9 and we can lower the LDLs less than 70 or even to 50. Otherwise, they don't get updated. Why did the 2013 get rid of the 70? Because we couldn't get them down. People were having myalgia with the higher dose statins. So they said, let's get rid of the 70 magical number. Now we can get them down. Let's get the 70 back on. You see what I'm saying? So all of this has so many other secondary motives. It's run by the pharma industry. As much as I support pharma industry more than any other physician, you got to realize why the guidelines exist and make sure that we are not caught into the so-called web of just following, like, it's just a guideline. It is not the holy holy book or anything you have to follow. So, you guys with me? So we talked about the 4 statin benefit groups. I'm not going to go into it again. And the new global risk assessment calculator. So I use the calculator quite a bit. People who have seen me in clinic, and Charles, you can attest to it. So this calculator is not something you can memorize. This calculator utilizes newer technology. We live in smartphone technology, so it utilizes apps available. And then also relative abandonment of non-statin cholesterol medications unless there are significant troubles attaining goals. If you notice, nobody really talks about any other drug. It's all statin, 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 statin. Why? Because statin drugs are actually extremely potent drugs in getting mortality benefit. The only reason they have more mortality benefit than any of the other drugs, despite lowering LDL, is because there's some element of anti-inflammatory. They get the CRP down as well. That's why. Although PCSK9s don't have the anti-inflammatory component, PCSK9 is like, holy cow, it's like, it's like taking statins and, multiplying it by 10 times. It's just so potent. So it doesn't matter. Your LDL goes so low, your risk has to go down. While statins have an inherent anti-inflammatory marker, so that's why statins are being, yes, but nobody's talking about any of the drugs other than statins. As Dr. Sharp alluded, we're going to just touch base a little bit on Zetia, which is ezetimibe, and PCSK9 at the end. So major changes to the 2013 was because they were not based on the LDL goals, and we wanted to focus only on statins, and the high risk people were initially were 20% risk or greater, they became 7.5 and greater. What happens when you lower that? More people get on medications. What happens when more people get on medicines? More companies make more money. Nobody really cares about, but statin is a good drug. I like to give you both sides of the equation. Somebody's got to be the devil's advocate. So atherosclerotic cardiovascular disease include clinical coronary artery disease, stroke, carotid artery disease, and peripheral vascular disease. So 2018 update included the less than 70 as a goal for people with have bad atherosclerotic vascular disease. We talked about the risk enhancers, the use of PCSK9 as Dr. Sharp alluded. So bottom line is, previously, if we couldn't get the goal, the only thing we had was Zetia. Zetia helped a little bit, but still some people struggle to get the goal. So people, if you are trying to get prior authorization, if you say they failed Zetia and statin, it's easier to get approved. So basically they're all going like algorithmic, right? So it makes sense. The practicality is, hey, somebody's not going to respond to Zetia, just give them the PCSK9. But the insurance companies and the drug companies, they don't like, the drug companies might like it, the insurance companies don't like it. Zetia is the preferred initially as an add-on. Interestingly, 2017, I found for the first time another society, which was not cardiovascular, which came out with a harsher guideline, which said, Endocrine Society in 2017 said, for people with really high risk coronary artery disease, you should get the LDL less than 55. So, that is where that came from. Having said that, there are studies which Praluent was involved, the Odyssey trial, which actually said that if the LDL was less than 50, they did not up-titrate the dose. So 50 could be a magical number, it couldn't be, whatever. So the lower. Now some other cardiologists explained and says, hey, listen, LDL is a bad guy. The lower the better. Even if it's a little bit of junk, eventually it's going to build up. So all of these are, you can hear so many different people say different things. Bottom line is, I'm a very, very conservative kind of guy. At the same time, I'm also type A. So it's a rare combo, because I'm like, I have to follow certain things, but I also have to make sure it's the right thing. Not just follow somebody one day, the next minute follow somebody else another 5 years later. You know, we are all educated people. We are all smart enough to be here. We all should be smart enough to make our own decisions and not just follow somebody who sits in a steak dinner right here and then make up some decisions just because they can do that. Okay, just because we can't do it, we're just sitting right here, right? So bottom line is, in my opinion, what you think is right for the patient is right. If you think it's ridiculous to get the LDL is less than 10, my opinion, if somebody's less than 10, I back off. Somebody's LDL is less than 10, I back off on the dose. Am I going to be happy with 70? Yes. If you look at the data in more detail, your PCSK9 data, actually the most benefit is only in people with LDLs greater than 100. Nobody will talk about it because they want to focus only on the guidelines. If these are drug reps who come and visit you, oh, you know what, you can still use it for somebody with an LDL of 80. What are you talking about? So, but again, having said that, would I use it? Yes. Why? If somebody is really, really aggressive coronary artery disease, who's having multiple stents and multiple MIs, get them down. Like the Endocrine Society had talked about getting it less than 55. If somebody's just had one stent 15 years ago, and they are 75 LDL, guys, let's talk about it with the patient. Let them know. So these are the 4 groups again, ad nauseum. If they have atherosclerotic heart disease, they have LDL greater than 190. If they're diabetic, and LDL greater than 70, and if they have a risk of greater than 7.5. So these are all sex and race specific formulas, and they use risk factors which are used in the Framingham risk score. And you have a clinical calculation for smartphones, or you can also go to the AHA website. These are the 2 apps which I've used. I use both of them. One is ASCVD Risk Estimator Plus. The other one is a Calculate MD, which has all the formulas. I think the Calculate MD on the right is a little bit more user-friendly or more aesthetically pleasing. The one on the left, all it does is a risk estimator and also gives you the 10-year risk as well as the lifetime risk. Although I don't know what to do with the lifetime risk. I had to search for it all over, and then I found out one particular presentation which had one thing but talked about lifetime risk. Let's not worry about it. Just focus on the 10-year risk. Okay? Any questions so far? How about doing some cases? Yeah? You are seeing a 42-year-old white woman for routine evaluation. She engages in aerobic activity, exercise 4 times weekly. She has strict Mediterranean diet. She's a non-smoker. She doesn't take any medications. Blood pressure is 128/70. Heart rate is 60. BMI is 20. Total cholesterol is 160. LDL is 70. HDL is 68. What is her 10-year and lifetime risk? If you calculate it, I'm not going to lengthen this presentation. Your 10-year risk is 0.3%. Lifetime risk is 27. Let's not worry about lifetime because I don't even know what we're going to use it for anyway. So, what do you recommend to optimize her cardiovascular risk? You see this? The 3 choices? Pick your choice on the phone. First one is A, second one is B, third one is C. There is no E. There's one smart aleck in this crowd. Looks like people are changing their answers very fastly. So, that's the only thing I can do is I have to manually advance it slightly. So, no statin, just maintain what she's doing to a lifestyle manner. So, that person is not statin candidate, and you don't need to optimize the risk anyway. Case study 2. 58-year-old Chinese American male who presents for routine evaluation, family history of CAD, does not take any medications, and is a non-smoker. BP is 138/70, heart rate is 70. Patient is overweight. Total cholesterol is 180, HDL is 55, and LDL is 103. Ten-year risk is 6.9%. Lifetime risk is 36. So what would you recommend? This is a tricky case, right? Why? It's because even the people out there, they can decide. ACC-AHA recommendation says 10-year risk between 5 to 7.5, you gotta give moderate intensity statin. The US task force, which modified it a little bit further, they say 10-year cardiovascular risk is not 7.5 to 10, no risk factors, so no statin therapy. Crazy, huh? What do? That's why I said it's shared information. Sit down and talk to patients and come up with it. That's why we come up with these cases, right? So the patient is hesitant to start new medications and notes in the risk estimator app indicate the risk score may be overestimated in people of East Asian ancestry, because the risk calculator is only asking you if you're African American or if you are non-African American. But for simplicity's sake, it says African American or Caucasian, right? So because you pick Caucasian doesn't mean that everybody who's not African American goes with Caucasian. So you can't really use that. So the patient has a valid argument. Maybe he's not 6.9, maybe he's 4. Make sense? Interesting, isn't it? So if you want to give a moderate intensity statin, so what would make you give this patient a moderate intensity statin, and what would not? Anyone?
Those things were not listed. What's his dietary intake?
What else? Family history. Guys, genes are huge. Genes show no mercy. I'm not talking about the denim genes. Okay? So you have to, you go back, that's the first thing that stuck out to me. So let's go here. Family history of coronary artery disease. Very important. So, which one of the following has been shown to reduce cardiovascular death, MI, and stroke in patients like this? A, B, C, D. Then I'll get the slide on, okay? You see that? Which of the following has been shown to reduce cardiovascular death, MI, and stroke in patients like this? Come up, just think about the answer first, and then I'll put the screen back on, okay? Answer now. What about the choice?
Yeah, it's like statin. So they statin is B, and then statin is C or B diuretic.
Everybody answered? What? Sure, let's go back. Is the question still on your app? No? It says case study 2? Yeah, 2. You guys got that? So answer the question. So let's see. A, B, whoa, 50-50, whoa, 54-46. Okay. The answer. So answer your question. For primary prevention, intermediate risk patients, no known CAD less than blood pressure less than 140 and LDL less than 130, statin is effective. ARB diuretics are not effective. So statin alone was the right answer. So there's a HOPE-3 trial outcomes. Again, looked at placebo versus rosuvastatin in people with an average LDL about 128. If you can see the graph, hazard rate, there's a big difference in the rosuvastatin arm versus the placebo arm. There's another study, I don't want to put all kinds of studies there. The old study, ASCOT trial with Lipitor, 10 milligrams, has showed 26% reduction in average middle-aged men with just average cholesterol. So statins do make a difference, and that's why they're all over. Unfortunately, the side effects also are there, and the intolerance is real. Case number 3, 54-year-old white female with hypertension, HCTZ 25 enalapril, Lipitor 80, 136 over 88, total cholesterol is 173, HDL is 46, LDL is 84. She has already achieved 42% reduction from baseline LDL of 146. How would you manage this patient? You guys all the information there? Your risk calculator says it's 2.8. 10-year risk. What would you do? Stop statin therapy A, continue Lipitor at 80, switch to rosuvastatin at 40, reduce to low intensity statin. I'll put the question up and then I can go back and show you. So that's the case study. For people who want to read that again, and you'll go to what do you want to do. That's all answered. You should say case study 3 on your phones. All answered? Okay. Whoa. B. What is the B answer? Continue Lipitor. What else would what other options would you rather like?
More information.
On the previous case. Let's go back a couple. His goal is not who got the right answer or what's right, but would you do anything else with somebody like that? Or what's your goal is the other question.
Family history.
So anyway, we'll get to another question. I don't want to delay it. So let's go. Case study 4. 24-year-old female. Are we doing good on time? 24-year-old female referred for dyslipidemia. Exercises 60 minutes in a local gym 5 days per week. Diet is low in saturated fats. No family history of heart disease. Blood pressure is 125 over 80. Lipid panel total cholesterol is 284. LDL 224. HDL 38. And triglycerides 125. Start high intensity statin regimen. Start a moderate intensity statin regimen. Start a low intensity statin regimen. Recommend lifestyle changes only. Let me go to the activate the question. I'll come right back here and show you the options. Does it show case study 4 on your phones? Does it say? Yes, I'll put the answers there. Let's see. 60, 30, 10. Let me go back. It's the only bad thing I don't like there. 60, 30, 10. So high intensity, moderate intensity, low intensity. The reason there's confusion is because you have a young person who's extremely active, who's doing all the right things, blood pressure is great, everything is good. What's the only bad thing? LDL is 224. So what's the guideline say? Any LDL greater than 190 is bad, high intensity statin. Because you're not dealing with any kind of lifestyle modification, you're looking at bad genetics. Genes are bad. What else bothers you here? Tells you, let's say if an LDL was not let's say if the LDL was, shoot, I went too far this time. Okay, let's say if the LDL was not 224. Let's say the LDL was 138. Would it still bother you? Somebody like this. Why?
It's genetic and.
No, LDL is. I'm changing the case study.
Oh, I
So
gotcha.
I said if the LDL was, everything else remains pretty much the same, okay, for the most part. If the LDL is 130, or let's even make it 110, would it still bother you?
Yes,
Why?
because she's so young and her lifestyle and her dietary intake.
It's all good.
Right, it's
So-
all exceptional, and so obviously there's something going on.
Why? LDL is 100, 110, everybody's going to have it. What else is bothering? What bothers them?
Cholesterol.
Forget it. Let's say total cholesterol is 190. What? HDL. She's 24. She's 24. Her HDL should be 65 or even 80 with the amount of activity she's doing. She's 24-year-old female. That sucker should be 85 or 80, right? For women, it has to be greater than 50. For men, HDL has to be greater than 40 under any circumstances to talk about risk. You are 24 and you're active like that. That's a big,
So
marker.
if you aggressively treat an LDL 224 and her HDL is already low, would you anticipate that a high intensity statin could drive the HDL lower? Or not?
With the high intensity statin,
Yes. Would it affect the HDL negatively?
it should. Actually, the only thing which affects the HDL is what? There's one lipid component which affects the HDL negatively. Or what is it? Triggs. Nobody's HDL changes very rapidly. Only people's HDL changes up and down is if the triggs go up, HDL goes down. If the triggs go down, HDL goes up. It's a teeter-totter. Literally. Other stuff should not, theoretically, at all. And HDL should actually go up. Especially rosuvastatin is shown to have HDL elevation significantly. So, I just wanted to touch base. I was digressing, but these are not questions I typed. I got them from somewhere, so I just wanted to make sure that we were not. So this talks about primary LDL high intensity statin. Okay. Case number 5. 68-year-old male admitted for an acute MI. Management prior to hospitalization, 30-minute brisk walk 5 times a day per week, 5 days a week. Is on simvastatin 40 for the last 3.5 years. Total cholesterol is 188. The LDL is 110. HDL is 42. Triglycerides are 184. Let's go activate the question and come right back. Okay. This is a case. Whoa, where did that come from? Is it supposed to be? Whatever, maybe it says case study 1 there, is that what it says? That's okay, just put case study 1 is fine. Well, answer A, B, C, D. You guys got it? Wonderful, 92. Why should we use high intensity statin?
It's just having their mind.
Yep. And simvastatin is not a high intensity statin. Case study 6. 72-year-old white male with type 2 diabetes and hypertension is presenting for routine care. Recently started on atorvastatin 40 1 month ago. Since then, he's started exercising 3 times a week. He's on metformin, HCTZ, valsartan. Blood pressure is 130 over 78. Total cholesterol baseline lipid panel 264, HDL 46, LDL 164, and trigs 274. Okay, got that? Continue high intensity statin and monitor. Switch to moderate intensity statin or rosuvastatin 20. Let's activate case study 6 and let's come back here. Everybody says continue high intensity and monitor. Monitor is the right answer because we don't know where we are going here. Because LDL, so what would keep you comfortable with somebody like that? What LDL will keep you happy?
LDL.
Yeah. Not this one, the next one, please. Would you care about the LDL at all? This one, you know, this is the one we were at, right? So everybody opted to continue on the Lipitor, right? So, and we just monitored. What would
50% reduction in the LDL.
if there's 50% reduction? We'll just monitor. Is that right?
Probably, and then see how it goes, especially since he started exercising and kind of see how that, you know, along with his diabetes management.
It really depends on what the next follow-up LDL is going to be, number one. Number two is, I'm not quite sure, everybody's different, but how atorvastatin 40 is going to affect. Practically speaking, generic atorvastatin is so much more inferior to generic rosuvastatin. So if somebody's 160 plus, I probably would switch in an anticipation, but the right thing would be to see what the next LDL is at. And how long do you wait before you get another LDL? I used to learn 3 months. The latest guidelines, latest expert panel is talking about just to wait for 2 months is more than enough. In the past, I know even 30 days is more than sufficient to have the statin drugs work. So if you're going to change any kind of statin thing, 2 months, and if the LDL is at goal, you don't have to bring them back for a year. So if the LDL is at goal, you don't have to recheck every 3 months now. Once a year. If the LDL is not at goal, you bring them back every 2 months till you get it. So that's a little digression because all these case studies are small, but I just want to make sure we get the point across, that's all. So, case study number 7. 40-year-old male with a 12-year history of type 2 diabetes is seen for routine follow-up. He is a lifelong non-smoker, he is active but overweight. Family history of diabetes mellitus, but no premature ASCVD. He is taking omega-3 1,000 milligrams per day and metformin 1,000 milligrams BID. Blood pressure is 123 over 75. Cholesterol is 130, LDL is 73, HDL is 40. Just got it? Let's go forward. Case study 7, or for some reason I changed to case study 1. So whatever is there is fine. So this is great. So there's some kind of
It says 7 on the house.
Yeah.
It does?
Yes.
Okay. You guys got all the answers in? All over the place, huh? C, B, and A. So C is the most popular. B is A is the next most popular. So C is lifestyle changes only, and cholesterol is already at goal. Is a B, and the other one is start moderate intensity statin. So who can support each one? Anyone? Why lifestyle changes only, or why moderate intensity statin?
Lifestyle changes, he can lose weight. He's not that far off from the guideline goals, so if he does a little more exercise and checks his diet a little bit better, he might be able to reach that goal without medication.
Okay. And why moderate intensity statin? Guys, 25% picked it.
I would say mostly because he has increased, what was that word that you used? Risk enhancers. Yes. With diabetes, so lower the better. And at 73, it's kind of right on the line. But that's why I went that way.
And I think very few people use that. It was a low intensity, I think.
Or,
Yeah. What is the G?
oh yeah.
Oh, cholesterol is a goal.
Yeah.
So what's the key thing in this particular case study? Now the two things, I'll tell you what as per the so-called, where I got the questions, what their right answer is. The right answer is A, moderate intensity statin, because they're, diabetic and they're not, because by guidelines, if you're diabetic and you're above LDL of 70, the LDL was 73, so it's 3 points higher, you have to be on moderate intensity statin. If your 10-year risk was less than 7.5, if your 10-year risk was greater than 7.5, you need to be on a high intensity statin, right? So that was the right answer there. But the question is, anytime you pick any answer, we have to be able to argue, and we have to know exactly why or what. So for me, above all, type 2 diabetes, 12-year history is as good as somebody having atherosclerotic heart disease. I don't care what the guidelines say or not. There's been several studies which show people who have been diabetic for more than 5-10 years, their risk of having an MI is higher than somebody who's had a heart attack in the past. Let me rephrase it again. Somebody who has diabetes, I'm just coming up with a 5 to 10 year thing, but somebody who has diabetes has a higher chance of having a heart attack than somebody who already has a heart attack, right? So by that definition, you got to be aggressive enough to make sure the LDL is at goal. Let's say the LDL is so close to goal, do we still need to put him on statin? Why? Yes, because our goal is not just get the LDL down, it's the anti-inflammatory plaque stabilization goal for it. So you can argue putting moderate intensity, high intensity, but not putting him on a statin is waiting for bad mistake. What else in this? I like the lifestyle modification thing, that's number one. Number two is the reason, I'll tell you why. Because one of the biggest thing I see here, which I think is bad, is he's taking omega-3. Why is that? Is because this is omega-3, it's a generic one. The generic omega-3 in our clinic, we've used almost 50%, we did a study, didn't we?
Sure did.
Yes.
Yep.
So what did we notice, Dr. Sharp? 50% of the people we gave omega-3 generic supplements, what happened to something?
People on A1C got worse.
50% of people, A1C got worse. Because you get Sam's or any kind of brand for cheap, you have all kinds of junk added to it. So you have higher risk of hyperglycemia and diabetes in that. What else? The omega-3s have both DHA and EPA. And what can they do? Raise LDL. So maybe if you were not on that, maybe the LDL would be 60. Who knows? You catch my drift? So that's why I like this case study. But obviously it's simplified, say, yeah, A is the right answer. But the thing is, there's so many learning points in this one study. It's huge. That's the right answer, I guess. Case study 8. We're doing good on time, I guess, yeah. 43-year-old male, white male with no significant medical history, presents for an office visit to discuss prevention of cardiovascular disease. He's a non-smoker, takes no medicines, exercises 2 to 3 times per week at a local gym. His BMI is 33, he weighs 215 pounds, his blood pressure is 134/80, total cholesterol is 190, LDL is 130, HDL is 39, trigs are 209. Guys got it? His calculated risk, 10-year risk is 2.2. Let's activate that sucker. Case study 8. And pick A, B, C, or D. You guys got your answers locked in? Your phone died? I have a charger there. Okay, let's see how we do it here. So A, B, C, D. So stress test, statin, aspirin, and lifestyle changes. Stress test, statin, aspirin, and lifestyle changes. Lifestyle changes and statins. Both are good. They're evenly based. So because we're talking about lifestyle and we're also talking about statin, right? So let's go back to the case. Let's go back and see why some people pick statins and why some people say lifestyle changes. So why would you pick statin here? Half of you guys pick statin. Why would you pick statin? Is LDL. So what makes you want to use a statin? LDL, but what was the guidelines? What? Risk score was 2.2%. So, okay, who picked lifestyle changes? Why did he not pick statin?
It talks about that he exercises 2 to 3 times a week, but I don't know how long he exercises, and I don't know what his diet's like. It doesn't discuss, obesity or anything.
So why
like
not
that.
statin?
I think that's probably a good place to start as far as lifestyle.
It's always lifestyle is going to be for everything, but it says lifestyle changes only. So why would he not pick statin? Risk is 2.2. Absolutely. It has to be greater than 7.5%. So if they have no other risk factors, everything is doing great, the 10-year risk has to be greater than 7.5% before you want to initiate any conversation for a statin drug. And that was also, if you remember the Chinese guy, you remember? He was 6.9%. And the ACC-AHS said he should be on a moderate intensity statin. The US Task Force for Lipids, they said no statins. Right? He's 2.2. Use the app. Sorry. Last case study for the day is case study number 9. 35-year-old male presents to discuss his risk of heart disease. He has a strong family history of premature coronary heart disease. Lifelong non-smoker, no diabetes, exercise 4 times per week, and eats a heart-healthy diet. Blood pressure 140/90, cholesterol 225, LDL is 160. Okay, so you have a 35-year-old guy who is LDL is 160, blood pressure 140, and he has family history of premature coronary heart disease. Consider low intensity statin, consider moderate intensity statin, or counsel on further lifestyle changes. A, B, or C. I don't know why it goes back to case study 1. Some flaw there. But A, B, C. What is A, B, C? So majority say B. Moderate intensity statin. So that's what the right answer, as per the answer key is, but the rationale. Patients likely to have a low 10-year atherosclerotic heart risk, but he does have a strong family history of premature CHD and an LDL of 160. Benefits versus risk must be discussed, and continuing heart-healthy diet and regular exercise should be emphasized. Why does it say patient likely to have a low 10-year atherosclerotic cardiovascular risk? Anybody else? Know why?
Does it take family history into account, right?
No, not because of that. Because he was 35 years of age. So the formula does not work. So when I have people like this, what I do, I just increase their age to 40. Okay, it can only make it, worse. If that fulfills, a thing, then we can go accordingly. So again, this is where you have to discuss with people. So obviously there's a big push for statins, and a big push for LDL less than 10. One of the conversations I have with all my patients it's easy to put people on statin. But what people fail to understand, let me see, make sure the slides are there. Okay, that's it. So, statin is a lifelong therapy. Let me add another thing. Any lipid lowering agent is a lifelong therapy. So before you start somebody on a statin, if somebody is hesitant to start on a statin, I would not force them to get on a statin. Say lifestyle management. What can you do lifestyle wise?
Dietary intake, exercise.
Yeah. So how can you lower your 10-year risk? Because you know what all is in the calculation.
Yeah, HDL, blood pressure.
Blood pressure, yes.
Waist rates.
What? Blood sugar, diabetes. What else is there? Non-smoking. So what I'm trying to say is, if somebody stops smoking, your risk goes down. Somebody doesn't want to take a statin, hey, stop smoking, your risk will go down. Let's see if you calculate what it is. Somebody's blood pressure is high, hey, try to see if you can lose weight or cut back on the salt. Maybe we'll recalculate your risk and see how much it goes down. Now, obviously, we can't change certain things if you're male or female, unless for California's sake or any other, or you can't change your family history or genes or anything like that. But things which we can change, we can. But people who hesitate, I never force them. I tell them, because once you get on it, guess what? When you stop it abruptly or get on and off of it, you risk of having MIs go up significantly. Yin-yang phenomenon, because you take it down, take it down.
So why not start him on a low intensity statin regimen and then recheck him in 30 to 60 days and see how he responds to it?
Okay. And then
see, because what if
as opposed to
the moderate?
As opposed to
Higher
moderate.
dosing. Right, yeah, low versus moderate.
That was the key, and I 100% agree with you. I always start low. I'm totally against high intensity. I don't put anyone high intensity. The only time I've really gone into high intensity is I've used the 40 of Crestor. The generic, it works great on people who've already failed. So when somebody is hovering over 160, I'm not quite sure how low is going to work. So you're going to use moderate anyway, because your 5 of Crestor or 10 of Crestor is moderate anyway. It doesn't come under the low intensity. The other reason is the low intensity, in my opinion, is non-existent, because they're basically generics which don't work or have some sugar pill in it, coming from some plant somewhere. Okay, so none of them really work. Pravachol is one of the best drugs. Guess what? You get generic Pravastatin, doesn't do squat. Why? Is it because it's a bad drug? No, it's not a bad drug. What you're getting is bad. It's probably not the real Pravastatin. It's not the real Pravachol. So I was really happy to see that the generic Crestor is really doing a wonderful job. I'm very, very happy. It's working amazing. It's working almost better than PCSK9. I've stopped using PCSK9 as much as I used to, just because Crestor 40 is working unbelievably well. And the side effects is not as much as I would have expected. So that's the rationale. The low I would never use. Number one, I never used simvastatin. It was worthless, is because so many side effects and so many drug-drug interactions and things like that. Right now, there's no reason to use any other statin other than Lipitor or Crestor. Use 5, 10. Crestor is easy, generic works. It's going to be cheap enough. Go for it.
I think I had someone Health Choice the other day who had tried 2 statins, and then I sent for Livalo, and they had to have failed 5 before they could be on. And I was like, 5?
Yeah, that's because there are 5. Yeah, it is kind of crazy. Yeah, bottom line is it depends on which insurance company, and doesn't mean I really agree with all those. And I probably will just try to, I just give them, I just play the game. I give them the samples and just play the whole game. Actually, more than me playing the game, Charles is the one who plays the game
Yeah,
himself.
teach me how to play the game.
Yeah, but unfortunately,
He was at 40, people can get for 10, 20
yeah,
bucks.
yeah.
I mean,
I
without
mean, she has a good point. The generic rosuvastatin you get for 10, 15 bucks a month.
Good RX is your friend. Yes, so.
Yeah, your Crystal's Express drug does it pretty good. I mean, so I think So that's in a nutshell. What I would. All statins are not created equal. I totally agree. And the reason why I focus only on Crestor and Lipitor, they say high intensity. before all those guidelines, they talk about moderate and high intensity. It's just kind of messed up. People are not talking about the real reason why it's high intensity. It stays in the body longer. Your simvastatin stays in your body 8 hours. Atorvastatin stays in your body 24 hours. Rosuvastatin stays in your body 36 hours. How do you give everything once a day?
That sounds like Vladimir. Yeah.
But do you understand what I'm saying? So, everything's approved once a day. You know why is it approved once a day? Because they did the studies on once a day, so they can't change that. So we're living in a very strange world where nobody is allowed to think outside the box. Everybody should just do like stay in the assembly line, okay, you're here, that's horrible in medicine. And that's why people still end up having, despite all the great drugs we have, we still end up having issues. Any other questions? You think the case study is helpful? I just didn't know because it was a very short case study, so I didn't know. But how it worked. I found a bunch of case studies together in one particular lecture. I said this would be a great idea to put them on there. And as I was going through it, I'm like, oh my God, this has so many different variations. Then you look at what answer, and it's like, what is the right answer? In my opinion, I individualize every one of my treatments. And you're absolutely right. I start with the lower dose. So if somebody is 70, 80, 90 of LDL or 100, I just put no more than 5 of cholesterol to do the trick, but if I really know somebody needs to get them down, bam, give it to them. PCSK9 is amazing. A little side note on PCSK9, as Dr. Sharp touched base, I never really had any differentiation between Repatha and Praluent, but for some reason, last 3 to 4 months, there's a lot more myalgias, including today, even in Anadarko when I went there, somebody was complaining of significant myalgias. So either the plant is different or whatever they're doing is different, I have no idea. Last 4 or 5 months, Praluent has had significant myalgias, Repatha has not. So as of 2 months, 3 months ago, I have not started anybody on Praluent unless if the insurance stipulates we have to start them on Praluent. Prior to, if you asked me 6 months ago, there was absolutely no difference. I used to be one of the bigger Praluent riders, but just in the last couple of months, for some reason. So either the plant or the lot, where are they getting it from? I don't know what it is. It's not just the samples, anywhere, pharmacy, everything. Everybody is having this. Any other questions? Nothing? Okay. Thanks so much for coming, and I think it was a wonderful discussion, and I think